Okay, our next speaker is Dr. Jerry John, who did his undergraduate, graduate, and medical education at University of Chicago, Michigan State, University of Utah, Wake Forest, University of Toledo. He's currently the director of the Heart Failure Clinic at McCady Hospital, which has been an excellent resource. His interests lie in mechanical circulatory support, left atrial pressure monitoring, and telehealth. And he'll be talking to us today about personalized medicine in heart failure. So let's welcome Jerry John.
Great. Thanks, Mark. First of all, can everyone hear me way in the back right corner? Okay, what about way back left corner? Fantastic. Great. So thank you, Chad, and thank you, Mark, and thanks for everyone for hosting, and thanks, Chris. All I remember from the movie Outbreak was Fear and Loathing, and I guess Chris is scared of MRSA and MSSA. So on the heels of fear, I guess heart failure brings fear to a lot of folks, particularly Medicare, because it costs them a lot of money. So I've stopped doing slides probably in 2010. I just don't find it very useful. So I'm going to leave you with just two messages. One, heart failure is going to change a lot in the next probably 10 years. It's going to become very personalized. And the second change that's going to occur is Medicare is going to be on your heels. And maybe I'll just start with Medicare because it's the issue of fear. So heart failure costs Medicare the most money of anything relative to anything. Stroke, pneumonia, DVT, whatever, pick your disease. Heart failure still costs the most. So back in the 70s, heart failure was, for the most part, a death sentence. It was worse than cancer. Mortality rates have dropped precipitously, but it still costs Medicare a lot of money. So Medicare, in its infinite wisdom, has decided this year that if you get readmitted in the next month after a heart failure admission, they're going to take away money. That sounds very similar to what the colonial experiment was with France and Britain. So France had a colony in Vietnam, and Britain had a colony in India. And they both had individual separate problems. The colony that they were having a problem with in New Delhi was with cobras. And in Hanoi, and outside of Vietnam, the French were having a problem with rats. And so they both had solutions. So the French and the British said to themselves, you know what we'll do is we'll put a bounty out, we'll put a reward for rats and cobras, because they were having infestations that were going through the sewers and this and that, and they were trying to create hygiene, and it was really a big nuisance. So they said, we'll give you X amount of rupees or silver coins or whatever the currency might have been for X amount of rats or cobras, because of obviously the humidity and monsoon season. And lo and behold, in the next month or so, droves of rats and droves of cobras started to come into the city commissioners, and they thought, wow, we're really making headway in terms of the rat and the cobra problem. And they started logging all the rats and cobras that started going up in the cities, respective cities. But when you go walk in the street and you take a bath, the rat would still come out of the bathtub, and the cobra will be still sitting in your shelf. And then they started to figure out that people got around the system, and in about 2 months or so, people were growing rats outside of Hanoi, and they were growing cobras outside of Delhi in the outskirts, because you were rewarded for that. So there's clearly no good deed that goes unpunished, and good intentions clearly have consequences. So in that same way, Medicare has decided that if you get readmitted again, they're not going to pay for it. So there's a consequence. It's created changes in behavior in America such that, oddly enough, readmission rates have dropped significantly relative to last year. But resource utilization has gone up significantly in terms of people in the ER, in terms of tests being ordered, casts, etc. So it's been an interesting conundrum with Medicare, and maybe they should have learned something from the commissioners in Delhi and Hanoi, but they didn't. So with that being said, unfortunately, government regulation is going to be on the heels of everyone. And our readmission rates in the heart failure clinic are about less than 1%. On average in the United States, they're about 25% at 1 month. Ours is about 0.6% annually since 2010. And the way we've done that is because we've shifted our focus to really rely on patients. And the difference is that way back when, there was people who just, if you start with movements, there was the artisan movement. You can make a cupboard, you can make a cabinet. And then there was the Industrial Revolution, and you can mechanize things. And then there were corporations, and there was economies of scale and comparative advantage, and you can make lots of cupboards or cars or whatever according to a certain design. In the same way, physicians started out as religious healers or shamans, and then kind of started doing funny things like trephining and letting blood and not washing their hands before they deliver, and killed quite a few people up until probably the era of antibiotics and septic hygiene, and public health probably saved more people than anything else in terms of stents or statins. But nonetheless, medicine will be changing significantly. And I'll just show you what we're doing at McKay. If you could roll a video, and this has to specifically do with personalized medicine. We're rolling people in a trial of left atrial pressure monitoring. And this is just a video of a device that we use in the cath lab. And it goes across the interatrial septum that you see here, and the wires navigated into the left atrium. And that wire then is connected to a pressure sensor, and that pressure sensor stays in your body, and it measures temperature and pressure forever. You don't need a battery, never needs to be changed out. And for the most part, it acts as a Doppler system. So way back when, the only way you could check the weather was to walk outside and see if it's cloudy. You can't have rain without clouds, and you can't have pulmonary edema without high pressures in your heart. But that being said, just because it's cloudy doesn't mean it's going to rain. Just because your pressures are high doesn't mean you're going to develop pulmonary edema. So this device is then given slack. It's connected to a very similar pacemaker system, and that's probably good enough for the video. And we're one of 2 sites in Utah that have been enrolling patients, and the goal of this trial was really the function of Medicare to reduce readmission rates because it costs Medicare so much money. And so we've enrolled about 7 patients so far, and the pressure data has been fantastic. And it's neat because now we've switched the responsibility to me and to patients. So they got to check their pressure. I find out what their pressure is on the internet, and we make a lot of changes. We find out when they went to Chuckarama or Golden Corral. It correlates very well. And we also find out I used to check 24-hour urines now, and I find out, yesterday we called, I said, how did you get 12.5 grams of sodium in your urine? And it was definitely Golden Corral the day before that led to that. But this left atrial pressure monitor is a new Doppler system, in the same way that now we can at least predict weather out to at least a week. The Farmer's Almanac wasn't too good for predicting weather. And so the Doppler system has been fantastic in terms of the left atrial pressure to prevent readmissions. There's about 70 sites in the world that have enrolled, and so far the data has been very promising. So this will probably revolutionize heart failure as we know it, just because readmission rates have been so high, and it's difficult for all the providers to get involved. And the other issue is redundancies, and so in terms of risk. So this is a huge risk population of getting readmitted, and the downside of the heart is there's not a backup. So you have a backup kidney, you have a backup lung, backup arm. So the body's, for the most part, created redundancies. Unfortunately, you do have a right and left heart, but they're kind of connected, and so you don't really have a backup heart. So in the same way that the Fukushima reactor blow up and a tsunami and a earthquake all occurred at the same time, that probability of occurrence was exceedingly low. The Japanese didn't really prepare for it, but cost them a lot of money. And there's insurance companies, and then there's reinsurance companies. And so Berkshire Hathaway owns Geico and reinsurance companies. They're all in the Bahamas, Bermuda, Luxembourg, kind of funny places in the world where they can be offshore. But they lost their shirts on Fukushima, and everyone's home insurance in the world went up. You may not know it, but it did because of one event. So because of that one event, it was disastrous. And so what's the one event that can kill heart failure patients? Well, acute heart attacks, acute cardiogenic shock, acute infection in the ARDS and sepsis. Those are big events that your body can not usually compensate for, especially if you've got baseline issues that don't work so well. And so in terms of the heart failure homeostasis, we've changed our clinic model in the sense that the body tends to do better with higher pressures, we've learned, rather than lower pressures. In the same way that your body tends to do better with a higher blood pressure for stroke rather than low blood pressure. If you're diabetic, you do better with a low or a high blood sugar rather than low blood sugar. If you're septic, you do better with a higher pH than a lower pH. So it's a really interesting right-shifted curve for most of human physiology. In that same way, we've just started to figure out why people do better with a higher left atrial pressure. And so this pressure monitor has been fantastic for figuring out heart failure physiology. And in terms of where we go from here, we'd be happy to navigate clinic patients. If you've got sick patients who keep ending up in and out of the hospital, this is another reasonable option to keep people out of the hospital. And so in terms of personalized medicine, this has become exceedingly personalized. Everyone has their own now unique pressure that we follow, and they have a range, and we figure out where their kidneys do best and where their lungs do the best. And it's been fantastic for putting power back in the patient's hands as well as clinicians' hands to try to do what's best for the patient. I think cardiology is going to change a lot in the next 10 years. And if you just look at FDA approvals for drugs, of the 20 new drugs that were approved last year, 11 were oncology. And they're very specific drugs. And so most of heart failure has been population-based medicine. You treat 10,000 patients, you get a p-value, you have a confidence interval, and then on average you can treat X amount of patients with Y drug to see if it works. But obviously not everyone responds to beta blocker, but we're forced to give people beta blockers. Not everyone responds to an ACE inhibitor or aldactone or whatever the drug might be. And so in the next year, I think technological devices with rhythm monitoring, pressure monitoring is going to be the same venue that the insulin pump has been for type 1 diabetics. It really hands off the control to that diabetic patient and says, you can manage your blood sugars a lot better than I can because you're seeing them much more often than I am. And making minute-to-minute or hour-to-hour or day-to-day changes are clearly much more beneficial for a patient if they're vested in their care. So with that, I will just open it up to questions about what folks have about what we're doing different in the heart failure clinic or otherwise with the pressure monitoring system.
Question?
Yes, sir.
How do you manipulate the atrial pressures outside of telling him to stay away from certain restaurants?
How do we, could you repeat that question, sir?
How do you manipulate the atrial pressures once you know what they are?
Oh, you mean if we don't have a pressure monitor?
If you do.
Oh, if we do. Well, to tell you the truth, what it does is it communicates with the patient with a handheld device. So it'll measure pressure if it's below 15, you don't take diuretics. If it's between 15 and 20, you take 40 Lasix. If it's between 20 and 25, you take 80 Lasix. And so every day it'll change the prescription. It'll pop up on your screen, and it'll tell the patient what to do. Take less Coreg, take more Coreg. Take less aldactone, take less Lasix. And so every day it changes. So the concept that we have typically for the past 40 years treating heart failure is, okay, we'll see you back in 3 months, 6 months, 2 weeks, 1 year, and we're not really changing things a lot, which I think is a disservice to patients because to assume that your physiology stays the same is like giving someone an insulin prescription and not changing it for a year or 6 months or whenever because your blood glucose or your blood pressure might change. So it really allows a lot more personalization and day-to-day changes. Any other questions? Yes, ma'am. Right, so this has been a really unique aspect because right now there is no treatment, zero, for heart failure with preserved ejection fraction. We don't know how to treat it. So everything that's been attempted for systolic heart failure has been tried with diastolic or heart failure with preserved ejection fraction. It doesn't work. So this trial has been very unique, and I've been arguing with primary investigators in Los Angeles and Ohio that we're having to rethink how we treat people. Their trial wants a left atrial pressure of 20. It's not appropriate for heart failure patients with preserved ejection fraction. They might need 25, they might need 27, they might be 28. And so we've targeted both diuretics and afterload reduction. So specifically either a long-acting diuretic or a nitrate, or depending at night, or hydralazine, whatever we can do to manipulate the afterload, because afterload reduction, meaning your systolic blood pressure, will also reduce your left atrial pressure. So it's not just a diuretic trial, and it's really left to the clinician's discretion. So I think at the end of the trial, in about 3 years, the guidelines are going to change for heart failure with preserved ejection fraction. So to answer your question, it depends on what type of heart failure they have and what the individual clinical investigator is doing. Yes, ma'am.
Question. So basically, the new stuff is just the monitoring, but there's no great new treatment for congestive heart failure. And so, being primary care, I mean, we're always, doing weights and checking
Right.
this and that. But my thorn in my side is the renal insufficient or, chronic kidney failure patient who has congestive heart failure.
Yeah, this is a fantastic. We've had one outcome where I was concerned, and I was quite consternated. So the trials run out of LA and Ohio, and they wanted me to push diuretics, and I said no. I said we shouldn't. They said, well, the gentleman's left atrial pressure was 28. I said I don't care, because he has 1.5 grams of proteinuria. He has nephrotic syndrome to a certain extent, a component 1.5 to 2 grams depending on when you check him, and he's diabetic kidneys. I said he needs a higher renal perfusion pressure. He needs a higher left atrial pressure, and because of the trial, we've learned a heck of a lot more new physiology about cardiorenal syndrome. What's the appropriate pressure and volume? Because obviously your point is pressure and volume aren't the same thing. You can be pressure overloaded, but yet not volume overloaded. It's a subtle distinction, right? Because kidneys are much more happy with volume, that you have enough flow to your kidneys, independent, because what we've learned is that diabetic kidneys don't do well. They don't renal regulate as well. They can't vasodilate as well, and so they technically need a higher renal perfusion pressure. And so for the cardiorenal patients, this has been fantastic. And independent of the patients who aren't enrolled in that trial, we've developed a new algorithm that will probably be rolled out in the Intermountain system in probably 2 years. It's still in the trial phase. It's called our renal algorithm, if you will. So I've created an algorithm for patients. They can log in on My Health, and it's a function of their fractional excretion of urea, fractional excretion of sodium, which obviously is inaccurate in diuretic-treated patients. But I've created a score which tells them if they're pre-renal or not. It's still rolling out. We haven't introduced it yet to the community, but we're just doing it with our heart failure clinic group. So that's a huge component in the world in terms of how to treat patients with a GFR of less than 30 and heart failure. Any other questions? Great, perfect. Thank you so much for hosting.